Now, in further questioning, Richard says that he's been compliant with his CPAP, using it 6 to 7 hours a night, and he's actually been taking it with him on his business trips. He had a sleep test done about a year and a half prior, and everything turned out okay. But oddly, when you question him about his degree of drowsiness, he says that, yeah, I've been a little bit more tired lately. In fact, when I'm driving home at night, sometimes I find it hard to stay awake, so I have to slap myself around and I have to grab a large cup of coffee. On physical exam, Richard's blood pressure is normal. His BMI, he's a little bit overweight. His Mallampati score is 2, so there's a little bit of obstruction. His neck size is not that bad, but his ESS is abnormal at 14. He looked at his old records, and it looked like he had normal lab tests done just 3 months prior. So which of the following measures are appropriate for Richard's continued sleepiness? Ensure he is using the CPAP properly. Refer back to the sleep lab or to the sleep specialist. Review proper sleep hygiene measures. Look for other causes of excessive sleepiness. All the above. Actually, yes, pretty much all of the answers are correct. Using the CPAP correctly is very important. Even though he said that he's been doing it, going over it, and getting more details of it is appropriate. Sending him back to the sleep specialist also makes sense because he's sleepy despite apparent proper usage of CPAP mask. It's always a good idea to go over good sleep hygiene measures. I mean, after all, Richard did say that he does have some alcohol and he's been smoking, so going over those is a good idea. And finally, looking for other causes of excessive sleepiness. Keep this in mind that a lot of patients with obstructive sleep apnea have other causes, like restless leg syndrome or periodic limb movement disorder, to name a few. As per your advice, Richard sees a respiratory therapist because his mask was leaking as confirmed by his wife. He's gotten a new mask and he thinks it's doing a little bit better. He's been a little bit more attentive to better sleep habits as per your instructions. So he's lessened his smoking. He's not really drinking, certainly at night times. But he still feels sleepy. Now, you did refer him to sleep lab for repeat testing, so we'll see what that shows. Now, one would intuitively think that if the apneic episodes are eradicated, that one's sleepiness should go away and they should be normal. But oddly enough, studies continue to show that even when patients have obstructive sleep apnea and they're adequately treated with CPAP, that drowsiness levels will not completely go away. We see here data from one study showing that an abnormal MSLT can occur in up to 65% of patients adequately treated. MSLT is a multiple sleep latency test. It is a daytime test to assess one's level of sleepiness. Also on subjective sleepiness, the Epworth Sleepiness Scale, about 34%, a third of patients will continue to have abnormal ESS despite being adequately treated. And finally, another outcome questionnaire, a functional outcome of sleep questionnaire, FOSQ, has been seen to be abnormal in about 43% of patients adequately treated. Take-home message, patients who are adequately treated, about 10 to 30% conservatively, will continue to have residual sleepiness despite adequate treatment with CPAP. So what could be the cause of this sleepiness that remains? In some cases, inadequate total sleep time is the issue. Even though a patient may say, yeah, doc, I'm sleeping about 6-7 hours or so, that may not be adequate for the patient. Sometimes the actual CPAP is not functioning properly, even though it appears from what the patient says that they are. So a patient's CPAP has to be considered and recalibrated in some cases. Please also note that in some people, as we discussed earlier, they could have other conditions that can cause excessive sleepiness, like restless leg syndrome, periodic limb movement disorder. Oddly enough, they may even have narcolepsy. And finally, psychiatric and other medical disorders. Please also keep in mind that medications can cause sleepiness, so let's question our patients on any medications that somebody else has prescribed that could cause sleepiness. Hypoxic brain injury, especially in severely afflicted patients, especially for a long period of time, has been suggested as being the cause for some patients who have excessive sleepiness and obstructive sleep apnea. And finally, there may be some inherent quote-unquote side effect of the CPAP mask. For example, if I take somebody who has no problems with obstructive sleep apnea, and I put on a CPAP mask on them, and they're allowed to go through a night or 2 or 3, how will it affect their daytime situation? So these are all the possible causes of sleepiness in patients who are adequately treated for obstructive sleep apnea with CPAP mask. So what are your next steps? Well, in A, we pretty much talked about these earlier, about CPAP therapy, mask fitting, etc. Sleep hygiene, we've already talked to the patient. But one other couple of things that we should talk about with the patient is maybe the patient should cut back on his hours to get more rest. We should look a little bit more at the possibility that the patient is not getting as much sleep. After all, the patient said that he was only getting 6 to 7 hours of sleep. He may need more. But one thing which we can also do is prescribe a medication to relieve that residual sleepiness. In other words, when all else fails and a patient continues to be drowsy, we want to help them become safer and have them get better quality of life. And it is for that reason that we can sometimes prescribe a medication. One medication that is indicated for the residual excessive sleepiness in patients treated with obstructive sleep apnea, usually with CPAP, is modafinil. It is the only medication indicated for this purpose. It's a once-a-day medicine with a half-life of around 15 hours. It's got a low risk of habituation, and it improves daytime function. Patients feel better when they take it, when they respond to the medicine. However, the medicine is a Schedule IV drug. It can cause some headache, anxiety, and nausea. It oftentimes requires prior authorization, and there have been some rare severe allergic reactions. Nonetheless, the medication can be considered in some patients who, despite everything that you can adjust and control and take care of, they'll continue to have excessive sleepiness. On follow-up, the patient has begun modafinil 200 milligrams in the morning. He calls you in a week as you advised him to do so. He's tolerating the medication quite well, and he feels a little bit better. He comes to you, to the office, in 2 weeks, as advised, and he says that he still is feeling better, but he's not as good as he'd like. And you do an ESS, and it's around 11, so it's better, but he's still abnormal. So you ask Richard to increase the dosage to up to 400 milligrams in the morning, and you ask him to come back again. Now, he does so, and after about a month or so, he says he's feeling fine, and he says that he's doing quite well with the medicine, and his ESS is now 9. We've been talking about excessive sleepiness and obstructive sleep apnea. It's a challenge for us in primary care to identify patients who have sleepiness, and for those who have obstructive sleep apnea. We should keep in mind, then, that patients come in suggestive of obstructive sleep apnea because of their symptoms or because of their risk factors. The challenge is to identify these patients because a great majority of them are going unnoticed. The next challenge is to figure out how much sleepiness a patient has by quantifying them, an Epworth sleepiness scale being the best tool that we have right now. However, keep in mind that sometimes we may not have as much time as we'd like, or maybe we become proficient at ascertaining the degree of excessive sleepiness simply by asking our own questions, like, do you feel sleepy in passive situations? As I said earlier, one of my favorite ways of doing it is to ask a patient, if I were to turn the light off in this room and come back in about 10 minutes, what's the chance that you'd be asleep? So ways of finding out how drowsy a patient is, and ESS being a very good one to use. Ask whether the patient's partner has noticed snoring or periods where the patient appears to stop breathing and startle him. It's a challenge for us to make sure that we ask the bed partner. Those situations where the patient does not actually detect snoring in themselves or doesn't know how bad they've been doing, the bed partner can offer substantial information. Another challenge is knowing when to refer patients for sleep testing. Earlier, I correlated that when somebody has chest pain and shortness of breath on exertion, that goes away within several minutes, and has risk factors for coronary disease, gets a stress testing. Analogously, when a patient has snoring and daytime sleepiness and has risk factors for obstructive sleep apnea, that patient should be referred for sleep testing. Please keep in mind that oftentimes this needs to be done expeditiously, because when patients are drowsy, they are dangerous to themselves and others. We talked about its effect in driving. So it's a challenge for us to make sure that we identify these patients who have obstructive sleep apnea and refer them appropriately and expeditiously. Finally, follow-up. Our patients come to us in primary care for advice, for guidance, and for keeping them healthy. When patients come back who are diagnosed with obstructive sleep apnea, we should ensure that they are using their CPAP mask correctly and that they do not have residual sleepiness. This is imperative, as there's a tendency for a lot of patients who are using CPAP masks eventually to throw them away. So to wrap up, there are a lot of sleepy people out there. Let's make sure that we identify these patients, and if they have obstructive sleep apnea, let's make sure that they get the right kind of treatment and also follow up.